I guess, long practicing single session person in and knowing, knowing the full context of how this is very different from everything else that's in our health system.
Mhm.
What do you think about this one or two door?
Well, my preference would certainly be the one door. I think if we just take a look right now at the two door that you have up here, there's a couple of things here that um, raise some concern for me. When we separate out single session as though people are appropriate or not for it, I believe we're setting limitations that are not always, that I believe aren't even, I think they shortchange people. I think people are only unsuitable for a single session or a walk in if they cannot talk anyway. And we'd probably say they were not appropriate for therapy at all. So I think anyone can benefit from a single session of counseling. And often clients will take only one session, whether we think they should or not. When we set it up as separate as this, then we're, again, not just limiting the practitioners, we're also, I think, limiting what's possible in that session. Even your language on this slide, I sort of caught me when I was reading it. When you say one at a time, solution-focused support session, is very different than saying it's a solution-focused therapy session. It implies that I am here to give you support. Or because I don't think we should be relying on clients to give us support. And that's really what we're going to do in this session. When in fact, I believe there's much more that goes on in the opportunity in that conversation that we have, and when people are coming to see us in often significant distress. When there's this administrative piece put on it, then the people who are in that it's almost an intake system you're talking. I think it adds a layer that's not necessary, and could create, I think it could minimize and also, makes single session look as though the walk-in was somehow a secondary source of intervention and not really as relevant or as potentially powerful as the other parts of the steps.
And I wonder, I know there are some people on the call, because while Heather was talking, I just scrolled down to see who's there.
Mm-hmm.
And I know there's some people on the call that have, as I perceive it, the two door version. I wonder if there's any of you that would be prepared to kind of talk about that and whether, what sort of led to that approach. And I also know there's some people on the call that have this version. Just checking in there if anybody has any sort of questions or observations or stories to tell about where you've been thinking about putting single session. Heather, maybe while we're waiting for people to kind of put their thoughts together. So this one door version, in the context of stepped care, I mean, that's not what people have normally been. I mean, they haven't been thinking about stepped care, I don't think, in the single session space. How do you see this changing the way you do single session, if at all?
I believe that when someone is thinking from a point of view that this could be the only opportunity we have to engage, that you're coming in not only aware of what is currently available around you in terms of services, but have a much broader perspective of what services are out there. I do not believe that I have the capability of meeting everyone's needs. And if someone is going to potentially see me only once, then it's important for me to, given the conversation we have, to be well equipped to introduce various other helps that could be useful to a person. So if there's already a system in place that has that stepped care perspective, and that, as people see on the screen, then I would be aware of what's available to people. So I could be offering those options to them, or I could offer them that you're welcome to come back to the walk-in anytime you like. Or if this has been useful for you right now, then I think that's fantastic. And think of us next time that you have, encounter a time in your life where you think this could be helpful. I also think that for this to work, and I think Monty raised this, the people who actually are in the step care, who are in the walk-in, could be the same people who offer those other services further up the service delivery ladder, for lack of a better word, because they would embrace the assumptions in their practice and in their professional outlook, no matter whether they're at the walk-in or whether they're, say, at the intensive group programming level.
Can you say a little bit more about that? So let's say that somebody has come to this walk-in and has seen you.
Mm-hmm.
Are there certain circumstances in which you would decide that they need something that's a little more like the traditional therapy model, or that you would step them up to, say, 7 here, or is that not really a relevant question?
I think it's a very relevant question, because I think one of the misnomers of using the language single session therapy, which is a very marketable title but not really representative of what goes on, is that people think that single session means they only have one session. And it's about the numbers. Well, it's not about the numbers at all. It's about shifting your thinking completely in terms of how you view somebody. So people who practice these ideas best use them everywhere they practice. Whether there's some organizations and even some universities where they might rotate people. So it's your day on the walk-in. Well, the way they would practice on the walk-in wouldn't be any different from the way they would practice if they were at step 7, where they might do intensive individual work with people, but they would still approach each session the same way.
Could you just describe that sort of process you go through?
The process is that I am thinking, what is going to be most helpful for you today? When you leave this session, when you leave this conversation, what do you want to stand out for you to know that this has been a good use of your time? I am very interested in negotiating with people about what they want. And people are able to do it through tears, through silence, I can offer options. I believe people do know what they want and what they're looking for. Often people never even ask them. Or they've never really thought about it. They've gotten used to other people telling them what they need. So whether I ask that in a walk-in, or you come back the next session and I meet you again. So between the time we last met and now, what do you notice is different? It's using those skills that you can acquire through various different therapeutic modalities, such as solution-focused therapy or narrative practice or motivational interviewing, and using them planfully to focus the time we have together that builds on the time we had before, and with the idea in mind that we don't know if there's going to be another session. So someone might need intensive therapy, for instance, who is really struggling with getting their anxiety under control, or they're finding it really difficult to manage the sexual assault they experienced 2 months ago at a party they were at in the residence. It's about offering service for as long as people believe they need it right now, knowing that when they need it again, it's there for them to have, and people aren't getting all caught up in wait times. Am I getting too distracted, or am I getting to your question?
I think you are. So I'm distracting by putting up these slides, so I apologize. But I thought this form that a version that you sometimes use. I wonder if you could say a bit about that.
Yes.
Both, so the modal visit at counseling centers is one. That's the highest on the frequency distribution.
Yep.
So if you could say a little bit about whether this is something you would use if people come back, or is it just something on the first time they come?
Yes. Paperwork, as much as we all hate it, I believe is an important part of the intervention that we engage in. That the paperwork, as Monty even mentioned in the previous webinar, is an intervention in itself. When we think about treatment as usual, the paperwork resonates and reflects the emphasis that we put in the conversation. It's often pathology and deficit driven and looking at history, because it comes from a particular belief system that values that particular knowledge. The orientation I'm talking about values what is important to you now, what strengths do you have, how bad do you think it is, what do you want to focus on. Well, certainly asking if people are at risk of harm. People sometimes think if you ask that in a pre-interview questionnaire, they're not going to answer it honestly. Surprisingly enough, people do, and if they don't, we have a conversation about it, and then that information comes out. And I trust people will tell me what they believe I need to know. When we look at asking questions like, remember a problem you had that happened sometime in your life and that you were able to resolve, we're tapping into memories of people that, oh yeah, I've been able to solve something before. Most people are not typically used to having those kinds of questions when they come in. So we're starting to situate them already to think about the successes in their life, not just the problems that they're bringing. And it doesn't mean to minimize the problems at all. It's about believing that life is a lot more complex than what we typically focus on, and that people are not one-dimensional. They're not just the problem, but they also have success in their lives. And it's highlighting that and giving people a sense of hope already that they might be able to move forward in this time, as opposed to relying on the other person to give the solutions.
Do the different questions on here give a bit of a kind of a template or outline of what a session would look like? I mean,
yeah, that's a really important question, because this way of engaging can be very challenging, and people can easily go back into a more history-taking problem story, whereas these questions help to focus the session, because this is the paperwork you need to do it during or at the end of the session. So it's the things you pay attention to, because these are the things you need to record. Now, this particular intake form here, a pre-interview questionnaire, or you could even use it as a recording summary, or there's a slight version, there's another version that's actually a recording summary very similar to this. There's a lot of different versions out there, and the questions are tweaked and changed depending on what people find useful or not. It's a living document, and I've taken these ideas from a variety of different sources, and I think it's important to credit people for that. This just happens to be a snapshot in time of a questionnaire that was used, and even now I might use something different, but with all the same themes in place.
Okay. Another thing that sort of just occurs to me around the rapid access single session. What do you think the relevance is culturally for people that are not from Western Eurocentric cultures, indigenous or otherwise? What's your sense of how this approach resonates broadly, globally?
Well, I'm going to be walking out probably on some pretty thin ice here, because my exposure to and experience with non-white folks is certainly limited, and I'm acknowledging that. But on the other hand, I taught these ideas in a graduate program a while ago at a university where there was an Aboriginal or Indigenous social work program. And a number of the students from that stream of the master's program did the course with me. And they were excited about these ideas because they said it fit with their worldview, or at least they could integrate it much more easily with their worldview, and found the questions much more palatable than more treatment as usual, or what are known as traditional sort of assessment-driven kinds of questions. I also recently had an experience in October of being in Saskatchewan in Canada and visiting a First Nations university, and was asked to guest lecture a class about time-sensitive or effective health in conversations. I call it a number of different things depending on the audience, sharing exactly the ideas that I would share if I was doing single session therapy training, and the students were excited about the ideas. I think it offers an alternative to people who want to embrace their particular perspective, but don't find that the more heavily, or shall we say that the more traditional treatment as usual approaches, just there isn't the same fit. Mm-hmm. So okay. I think it's possible. I think it's about a way of listening to people and actively engaging them in their own futures.
Okay, thank you. Is there anything on this slide, Heather, that that you think is probably important. The assumptions and the goals. You've talked about when you do your trainings. I think you talk about assumptions
Yes.
and goals. So, tell me if there's anything here that you think is really important as for an administrator that's thinking about implementing.
Oh, it's interesting. These are different than the ones I would have. There's lots of different lists of assumptions out there in the single session therapy world. And I think it's important that people find the ones that fit for them.
Okay.
So I have a sheet that I hand out when I do training. And I said, it's important for you to find what works for you. And can you go back to it?
Yep.
There we are. I think believing that change is constant is ongoing is very liberating for me, because even though I might not see change happen in a conversation at the time I see somebody, I do believe that it's going to happen anyway, and that I have had something unique occur with this person, and I really don't know how I'm going to influence them in the future. So, but that gives me some hope. The interesting one there is clients must want to change. I wouldn't language it quite like that. I believe that what's important is that I need to be aware of what stage of change they're at in relationship to the problem they're presenting. I find the stages of change by Prochaska and DiClemente as some of the original developers a really helpful construct in at what level of active engagement should I have with the person when they come to see me. And
so clients are so basically what you're saying is that clients are ready to change. Our job is to figure out what it is.
Exactly. And they might not want to change what we think they should change.
So capturing, as Masha Tolman suggests in the title, capturing the moment of opportunity.
Yes,
is
that's right.
Yeah, okay.
But these types of assumptions and others like them, I think help to reshift our language, because if we're going to believe this, what kind of conversation do we want to be having? What kind of questions would we be generating to reflect these kinds of assumptions?
So what do you say, what would you say to a director of a counseling center who is in a institution for which this idea of taking a history is essential, because we don't want to miss anything. The people that come in and do threat assessment training, they often say, well, there's no, I don't think I agree with them, but there's, in every case where there's been something, a disaster that's happened, a shooting or something, the pieces and the clues were there, but we just didn't put them all together.
Oh, that must be so heartbreaking. I mean, really, we want to believe that we've missed something, because then maybe we could have stopped it. And that feeling of lack of control is just probably one of the worst things we experience as a human being.
Okay.
And so we keep thinking, there must be something we missed. Must be something we missed. There must be some way I could have stopped that.
So what's the danger of taking this approach that we have to get all the clues and we have to keep assessing for all the deficits? What do you think the risk is of that?
That we're probably not going to get very far in terms of helping people to move forward.
Because you're going to be focused on everything that's wrong with them.
That's right. And everything that's already happened.
Yeah.
And you know what? If it was that predictable, I don't believe it is. I mean, intimate family violence or intimate couple violence or partner violence or national violence, we continue to think we are going to figure it out, and we haven't.
So this really means trusting our clients and having faith in them to tell us what they need.
Yeah.
And that we trust them to tell us if they're at risk.
Yes. And that is very scary, particularly when we're new in this kind of work. Because there's the fear, what if they don't? And you know what? All the questions in the world, people still don't tell us things. And if people, if they really want to die, they will.
Right. So for someone that's worried about being sued if they don't do this, because that's often the conversation that I hear.
Yeah, well, let's cut to the chase. We live in a risk-averse society.
With our colleagues in the United States, much more litigious.
Yeah.
How would you articulate this model as being safe? How do you
ask
say this is actually safer? I think, is it safer maybe?
I think safety is a relative term. I think you're talking about two sets of beliefs that run counter to each other. And I don't know if there's going to be anything I can say to, say, a manager or a CEO or a director of an organization if they are deeply entrenched in the belief that people are hiding things from us and that we need to keep asking until we found out everything.
So we have to trust.
Yeah. And it's turning that belief around and suggesting that people are coming because they want something different in their life. And even if they're being brought, because often, it's not unusual in the university setting for, someone to bring their friend or, or they're coming because they've been talked into coming, whether their parents have or they're, the head of residence or a teacher or somebody's told them. Even in those situations, I think we can open up space for a conversation that suggests that they can live a different life. I think we need to be less focused on outcomes that are tangible. This whole idea of evidence-based practice, I'd rather think of practice-based evidence. Someone coined that a long time ago. I happen to really like it, so I've made it mine. Is not as it doesn't create that same level of security for us, but I think we also can create a false sense of security if we think that our questions somehow about pathology and history and knowing everything that could go wrong is actually going to make a difference in people's lives. And honestly, to some people, this might sound really naive, what I'm saying, but I have seen relationships transformed. My history professionally was in children's mental health, where the kids with only the highest level of risk problems were presented. And it makes it, these ideas make a difference.
So, so the risk thing, my wish would be that, because I like the practice-based evidence, and when I talk about stepped care, I say that's a real cornerstone. That if we see people, we have to measure. And if we see people only once, we have to measure. And you could measure. You could do a scaling question at the beginning and the end of each session, or you could use something like the. Monty was talking about this earlier. They use in their clinic Scott Miller's outcome rating scale and the session rating scale. And he sort of wondered out loud, well, maybe we could do one at the beginning of a single session and one at the end to see what the movement is. And he even mentioned that they sometimes do a telephone first contact, which isn't just a triage. It's actually solution focused, and they'll there's a version of this that you can use over the phone. So what do you think about what we need to do to monitor within the stepped care system? Do we need the symptom stuff to manage risk, or is something like the OARS enough? Or the form that you use?
Yeah. I would say it's going to depend on what people are really looking for and ultimately what are funders wanting. A lot of the paperwork we have to do or I've had to do in the past is often driven by what evidence the funding bodies are wanting to see. And sometimes we need to live in that place of dissonance where we want to work from a strength-based perspective, but we've got people who want all the problems.
Yeah.
So it's about having both, and maybe at times we need to do that whether we like to or not. So it's about where do we situate those questions? How can we make the session as focused on what the person wants? We talk about client-centered work, and yet so often it's not, because we take the lead so often about in the direction we think it needs to go to, but it's about managing to do a both and. I'd be very curious if there's anyone on the line who has any kind of reactions to what we've been talking about already. Because I feel like I'm hearing my own voice and I'm thinking, boy, Heather, if I was listening to you, I'd probably be going, oh yeah, right. Like, like what is she talking about? So I think I'm a little curious if there's anyone out there that's got some sort of thoughts or responses that they'd like to make about what they've heard so far. Is that okay to bring forward, Peter, at this point?
And be sure to take yourself off mute.
Okay. Oh yeah, not me. I love interpreting silence. It can mean so many things.
Remember, we can see you all.
We can see you.
Cheryl, I see you there, and you've got some people in the room. I'm wondering what your thoughts are on the maybe back to what we were talking about earlier, the walk-in access, and sort of how you came to be where you are, and what you think about this question of one or two doors,
or even anything else you've heard so far.
Yeah, I think you're on mute if you can hear me, Cheryl. Susan, are you able to oh, there we are. Hi, Cheryl.
Sure. So I'm here with Terlyn and Kirk, and this is incredibly relevant for us. We're sort of in the throes of looking at how we can integrate single session therapy. We've had one set of training in the fall for all of our staff, and we have another 2 days planned for beginning of May. I'm really intrigued, and I'm going to let Terlyn and Kirk jump in, but I'm really intrigued by kind of almost rethinking the whole approach across all aspects of service, so that students coming in are sort of introduced to the idea that many students find, that the single session can be sufficient to meet their needs. And then with every touch point, there being that option. And I think as I'm hearing, it does require the mindset of the counselor to be sort of just assuming that that's the case. So, on the one hand, it can be thought of as something that's quite straightforward. On the other hand, I think it's actually quite complex. Really think about redesigning and rethinking the entire operation along those lines, and very exciting to think about that, particularly with post-secondary and what we know about our students and the way in which they, just in time, wanting to be able to access to be able to get back on track. They're not necessarily interested in diving into all of the issues, all of those kinds of things. So I'm very, very interested in looking at how, what the implications of this are on a operation like ours in post-secondary.
Are you more here? Like, would you say you're more with this too? Am I correct in assuming that at this point?
I'm sorry.
Are you more at the two-door sort of thing, that you have your well-being people at UBC that are sort of doing a walk-in clinic, and then there's this different sort of place to go to get into the stepped care? Or would you say you're closer to the figure two?
Right now, the way we're functioning is actually that from our triage team, people are being referred into single session. So there's a conversation with the student. That is not where we would like it to end. I think we would like to segregate it more actually for the purposes of staff being able to conceptualize it as different, because what we're finding is that staff, when we have it as sort of in the same system, that they are that because of the way they're trained, they're just taking those people into their care and continuing on. Whereas if we had it more isolated, where actually they can't even have the option of continuing with that person or kind of referring into themselves, that we can, because it's as much having to have staff be able to conceptualize that something really powerful can happen in one session, and we just need to deal with what comes in today, as opposed to, you know, this long historical context, as it is marketing it to the students. Yeah.
So there's something that you're talking about that I think it probably is different from both of these figures.
Yeah.
Is that?
And we're really kind of in the beginnings of thinking about what kind of a system we do want to set up. Our plan is to make the shift in the summer at some point, so that single session becomes, you know, just a part of our operation. And so this is very timely in terms of thinking about how we actually do that.
So this might be closer, though. I'm thinking that the first point of contact would be very much single session, and many people, that's all they would need, but everybody would do it. Everybody would be adopting these principles at all levels. And Heather, I'm wondering if you shared a comment about psychiatric residents in our earlier webinar with the small schools, because they're traditionally operating up here. Just share with me a little bit about your experience with the psychiatric residents.
I've done this training with psychiatric residents, as Peter's pointing out, and probably it's really interesting to see how these two paradigms or discourses of understanding really clash with each other. That for good reasons, psychiatrists are being trained to do particular kinds of work. And these psychiatric residents were in their placement in emergency centers, in emergency settings in hospitals. And so they would get called in because someone was in acute distress or was acutely suicidal, or there was something, the word acute would typically get used. And if the person was capable of having a conversation, they would typically go in and do a big assessment about what the problem was. And then at the end of the conversation, they might ask, so, you know, is there anything else, or what could be helpful for you? And all I suggested was, what would it be like if you asked that question at the beginning of the assessment? And they were stymied. It was like the pushback I got was quite profound. They had a hard time seeing around how that first they didn't believe that question could be helpful because they didn't think the person could answer it. My belief is that people can answer it, and that if we actually let people know that we're interested in what they want, they might be more likely to engage in the suggestions or recommendations that we have at the end. And so even just that simple change of a question, which is part of the template that I share, and that's often part of many of the writings around single session therapy, it's that opening question. How significant and how important that opening question is, that can be asked for every single person you see and every time you see them. And that ends up creating a context, or context for the conversation as it unfolds. I think one of the dilemmas I've run into here in Newfoundland and Labrador that's not unusual in other work that I've done in Ontario and Canada is that we've seemed to have run into some really significant overlap with professions. That you've got social work, psychology, and psychiatry and other similar types of disciplines, including nursing, that have these big areas that we're so-called doing all the same work. And I think that's created sometimes a bit of a dilemma about who do people need to be seeing and what do they need to see them for. And I think the nice thing with the step care template is it's identifying that we do come in with different areas of expertise and different content areas of knowledge. And that I think is helpful for clients and for us as service providers to know who we should be engaging in to help this person with this particular issue. But I think all these disciplines, as Peter's just called them up now, could all still come from the same assumptions of resiliency and strength. And I think that would change the conversation over a step care plan.
This is a very messy slide, but it just sort of suggests that, people are working at all different levels. And the reason I started thinking about this kind of a slide is because the scaffolding, step care scaffolding can help guide conversations about who will do what, when, and or you could abandon the whole role differentiation thing and go back to the slide that we had up there, that people are going to operate at as this suggests, try and bring in the strengths focused in whatever discipline you're in, whether it's so for the residents, Heather.
Yeah.
So you taught them single session.
Yeah.
Interviewing.
Yes.
Any sense of how they might or would or did integrate that?
There was a certain level of skepticism that I somehow was negligent in not asking certain questions. And I've had the same reaction from clinical psychologists and certain graduate level trained social workers. So it's not just discipline specific. That if I'm not asking or inquiring about the depth of the problem and the surrounding variables in their life that are causing distress, then somehow I am being negligent or even unethical. And I believe that is very problematic. That's coming from a place of that all this information is needed in order for us to be helpful. But I'm not particularly interested in being the only one to offer solutions, so I don't need all the information. I believe people have all the information about their lives. My job is to help them to figure out what parts of that information are going to be useful to them. It's possible down the road, if what we're doing together is not making the changes somebody wants, that I would want more information. But it's really about the step care idea that as we move up and become more intensive and more intrusive in our practices because of the nature of the issues people are presenting, that we will go for more problem-focused information. But I would hope in that conversation, we would also look for success-focused conversation as well. The fact that somebody's actually coming for help says to me, whether they were brought there, dragged there, or whatever, they're actually there, whether they're on the phone, a computer, or whether they're face-to-face, that there's something in them that's saying, this is a good idea right now. And it's my job to figure out what part of them is saying that.
I just noticed that Anne-Marie Churchill joined from our
she has. Hello, Anne-Marie.
Newfoundland. Are you unmuted, Anne-Marie? Can you hear us? Oh, Anne-Marie?
I got 10 minutes left. Yeah, yes. I see your name there.
So I'm gonna pull her in as soon as she's on, because I know one of the questions that's come up, and maybe Heather, you could weigh in on this, is people who have issues with trust, clients, students, folks that have experienced trauma, need some time sometimes for that trust to evolve. What do you say to critics that would say, look, to offer to not sort of promise that I'll be here with you for a while might mean that we people.
Peter, I'm losing what you're saying because somebody else's mic.
Oh, yep. Hi. So somebody joined, I think, that's not on mute. There we go.
There we go.
I think it's Anne-Marie, actually.
Yeah, just making all that noise and interrupting you.
Thank you, Anne-Marie. So Anne-Marie Churchill is our project coordinator in Newfoundland as we're rolling step care out across the province, and also a big part of that single session. And Heather's led that. So the question was about trauma.
Yeah.
And some of my colleagues, counselors and clinical psychologists would say that you need to build up trust, and people aren't necessarily going to tell you what about the trauma, even though maybe they need to. And
I would be very interested in who thinks they need to tell me about the trauma.
Okay.
Is the client believing they need to tell me about the trauma, or is it other professionals that think they need to tell me about the trauma?
Right.
I'd be more interested to know, how is this trauma, and I would want to be clear with the client if that's the word that they would use or whether that's the word that's been given them in terms of the event or the experience that they've had, how they would define it. But how what is it about this experience or this event that is impacting you right now that you believe you would like to have different in your life? Mm-hmm. I'm more interested in how people live with the experiences they have and what's going to help them to keep moving forward. And my professional experience has been, and is that people who've had significant trauma in their life are pretty quick about deciding who they want to talk to and how much they want to say. So I'm willing to work with whatever they choose to give me, because for me, that's what's most useful and respectful. And later on, if they want to talk about more about those events, then they know they have someplace they can come, that they can actually determine how much is said and how useful it is to them.
So you would say this is a trauma-informed therapy?
I would say so, yes. Just maybe not according to traditional practices of trauma.
Okay.
I don't believe big problems need big solutions or long-term solutions or long-standing solutions. That just because you've had what we consider a trauma occur to you means that you now need to have 15 or 20 or 50 or 5 years of therapy.
Mm-hmm. Yeah. Okay. Do we have any questions? I'm aware of our time, but I think we do have some time for questions or comments.
I'm glad that's your calendar that just came up and not mine.
Yeah. That's my sabbatical calendar, yes.
Yeah, well, mine doesn't look like that. It's a lot more colors.
Yeah. Folks that are, especially folks that have been implementing single session, this is a chance to kind of tap Heather's brain and
so can you take off the mute? Hi, Peter. Can you hear us?
Yes, I can. Hi, Len.
Hi. We are, as you can see, we are a group of people, and we have more people that the screen can allow. So hi everyone. We are at University of Victoria Counseling Services. This is our year 2 step care. Here at UVic, we call it collaborative care. First year that we have quite some struggle, and then just this past September we implemented 2 doors. One is one door, the other is single session. And then I think that when I'm listening to the webinar today, I think it just struck me that are we talking about single session as a therapeutic approach? Or are we talking about single session as a service delivery model? Mm-hmm. To feel a little bit different. And then I appreciate, Susan, your input about how you can see how you can use a single session as a therapeutic tool and to treat every single session as one at a time, like you talked about. But I have a little bit of trouble to integrating how the single session as a service delivery into the step care. And then I will be curious to learn from other centers that any other successes, any other way to tweak this model, so that we can improve our own model.
So the question is, how do you, a little along the lines of the discussion around psychiatry residents and people that are practicing more traditional, I guess, orientations, is how to bring this practice integrate it with what they're already doing. Is that kind of what you're curious about?
Maybe. I think that I'm just kind of curious about other university centers that have implemented 2 doors versus 1 door. We are a team that a lot of us are done training in narrative approach, have done solution focused, and we are very strengths based. And then I think that there's a lot of things that spoken here today really echo with our values. But just looking at the service delivery model, to look at 1 door versus separate doors, and then to figure out how are there other centers that deciding to go with 1 door, integrating single session along with a step care, and any other considerations there. So right now we have 2 separate doors. So
I know Jillian, my colleague Jillian from George Washington, if you're comfortable unmuting yourself, Jillian, yours is a one door. Am I right?
Yes, it is. Hi, everyone. Yes, we have a one door. We do share the reception with our medical services, and that in itself did pose problems for some of the students because they demanded one door so that nobody would know that they were coming to mental health services. Yes, so that was an issue, but now we have about 4 different doors, so that seems to have addressed the issue.
But they don't. You don't sort of have a single session thing that's separate from your walk-in. Is that correct?
No, we don't call it a specifically single session, but the expectation is that the session that the therapist has is of a single session component. And I have to thank you, Heather, because you touched on the First Nation view of single sessions, and it really does resonate with me because it is, when you come from a different philosophical foundation or value system that's different. So my own is from the, my Caribbean roots. We were taught that you only have one interaction. You can't assume that there's going to be another interaction that you have with an individual. So in that particular context, you have to make the most of it. You have to treat it as if it's the only one that you have. And when there is a community or culture of trust, that's when you can actually go straight to what the issue is. So there's no kind of time wasted. You're thinking, look, this is it. We've got to value the time that we have.
Yes, thank you.
So I think I'm aware of our time, but I actually think that this is more common, the 2 doors. So Elan, I think that's, I've sensed that that's happening at a number of, especially Canadian universities. Dalhousie has that version. I think McGill is not sure where they're going to go with this. They want one door entry, but whether they're going to have a separate single session clinic or not. And discussing this with Monty, this is still an open question. And so I like the fact that you asked that to the whole group. Are there people that are doing a separate door, an outer layer that is that single session contact, and then referring into the more intensive care as a separate entity? The struggle though that might be easier, I think, to do initially. That might be a first step. The problem with that is that it may not then get changed for your other practitioners to adopt more of this recovery model, because you've now specialized that out to the single session department. Your thoughts, Heather?
Yeah, I would echo that. The organizational management of these ideas is such a challenge. It sometimes I almost find it distracting because it can take away from what actually goes on in the conversation and the belief system of the practitioner themselves. And I think they're just such, they really, sometimes they can feel like it's the only important thing to be talking about. Whereas I wonder if we could spend more time talking to all the practitioners, all the clinicians, all the service providers, and asking them what informs their practice, what do they go after, what do they believe is important, what do they think they need to know, how long do they think they're going to take to get there, how long do they think they need to see someone, and start unpacking some of those beliefs. It makes me wonder what type of system they themselves might decide to implement if they were able to agree on assumptions that would inform their practice. And I know I'm not sure how particularly helpful that is, but I see this kind of discussion not just in universities, but in all kinds of mental health and addictions type settings. And anyway, I just,
Okay.
yeah.
So we're not finished, obviously.
Obviously not.
So I would invite all of you to correspond with each other by email. You can certainly correspond by commenting on the blog, or even better yet, if you have an opinion that you'd like to put into the blog, I'd be really, I'd love to see that. So the two-door version, or even the question, Elan, if you wanted to kind of pose a question out in the blog, or to the director's list. I think we need lots more thinking about this. It's as Heather said, administratively, this is hard, and we haven't really worked through it well enough yet.
I want to thank you, Peter, for this opportunity, and for all of those who have participated, even as listeners, to this hour. And I would certainly be interested in any feedback people have, or questions, or queries, or different opinions about what was said as well would be really interesting for me. So thank you.
And so March 19th, we will have another webinar on step care, and the focus will be on group work. And I think I voluntold Cheryl, you and your team, and there may be some others that want to sort of join in on a panel. So anybody out there that's really being creative and having some success with group work, it would be, let me know if you're interested in sort of having a conversation in front of 50 people. So that's March 19th, and this session is recorded, and so is the one we have with the small schools, where Monty was able to join us. So that will be up online. I'll have it on my blog in about a week's time. Thank you, everybody.
Thanks.
Thanks, Peter.
Peter, can you stick around?
Sure. Yep.
Maybe Anne-Marie as well, if she's still there.
Yeah, I'm not sure. Maybe it wasn't Anne-Marie. It might be somebody from MUN that joined on.
Well, it did say Anne-Marie Churchill.
That's true. It did. Yeah. I think maybe she was traveling.
Oh, she's training in Goose Bay.
Hi, guys.
There you are.
I sent Peter a text because I signed on inside the Salvation Army building in Goose Bay right after the training, and then I got kicked out. So I'm out in the parking lot, and my Wi-Fi is going in and out.
Yes. Yeah.
I'm flexible, like the steps care system. I'm in the parking lot.
Yep. Good. So
how did it go?
I think it was good. It was it was a bit different when we had Monty on. That sort of threw me that he wasn't, like, I only found out that he wasn't attending the second hour at the last minute. So that kind of threw me off in my moderator role. But
well, you recovered well.
And I threw a few curveballs at you, Heather. I hope that.
My gosh, some of those questions.
Oh my God, yeah, terrible.
Did you bring up any novel points or things that we haven't really touched on yet from a different perspective? I wondered.
I think the idea of he had a few ideas around monitoring. One was this idea that you might do something like the BHM, anything that has sort of pathology. If you need to do it, you might do it at the end, so it doesn't throw off the conversation towards deficits. But then, of course, you would have to have somebody look at that and respond if there's danger.
Yeah.
Yes.
We're from Central Michigan University, and one of my counselors has a question. Can we ask a question still?
I'm still here, and
I'm still here.
We haven't been cut off from Zoom, so let's keep. If that's okay, we'll keep going. Heather, if you need to go, just go. And Anne-Marie.
No, I'm good. I'm good. Hey, I don't get this opportunity much. This is fun.
Yes.
It's great to listen to some of my fellow Canadians.
Okay.
I used to work in Ontario in a psychiatric hospital there.
Okay.
And we used that COPM. And I wondered if you had used that, the Canadian Occupational Performance Measure.
Oh my.
Program. And it was a very client-centered, very quick way of assessing how clients perceive their progress. So it was just 3 steps. They identified what they wanted to change, a scale of 1 to 5 where they thought they were in making that change, and then their level of satisfaction. So they could either look at then, so for example, if their goal was to be able to manage nightmares when they woke up in the middle of the night, if that's the goal, initially they might rate themselves as a 1 out of 5, and their dissatisfaction is very low. As they learn skills, they might still have nightmares and say, you know, that hasn't stopped, but I probably at a 3 to 5, but my satisfaction might be a 4 or a 5. And it was a very quick way that was client-centered. And I just wondered if anyone had been using the COPM.
COPM, Canadian Occupational
Performance Measure.
Performance Measure. I'll definitely look that up.
Sounds like a nice little measure.
Excellent. Okay.
Thank you.
Yeah.
I'm intrigued that there's still 22 people online. I guess they're hoping to hear some secrets or something.
Or maybe there's questions. Any more questions? No? Okay.
Peter,
Emery,
sorry.